Fernando me avisa cuando empezamos.
Ya empezamos.
¿Ya? Ok. Bueno, buenos días, buen día,
Good morning.
good morning. So welcome to the first FSM PAHO webinar on healthy aging. My name is Marta Peláez. I'm the chair of the Healthy Aging Committee of the Association of Former Staff Members of PAHO. One of the goals of the Healthy Aging Committee is to offer educational programs that engage members with experts in the fields on various topics related to healthy aging. The purpose is to help us maintain function and quality of life as we get older. Before passing the microphone to Gloria Ko, President of FSM PAHO, and to Enrique Vega, Chief of the PAHO's Healthy Life Course Unit, for their welcome, I want to remind you of a few features for today's webinar. The webinar will be an hour and a half, and it has simultaneous translation in English and in Spanish, thanks to PAHO. Thank you, Enrique. To select the language you need to click on the icon, the global icon, to select your language. We're only offering translation in English and Spanish. So, in order to, para acceder a esta interpretación, asegúrense de conectar.
In order to access the interpretation, please just go down to the globe icon with the language of your preference.
Are done via the Q&A icon. Please use only the chat to communicate any technical audio issue you may have or any comments to the general participants, but to communicate questions that you want us to address with the presenters, use a Q&A icon. So this program has been recorded, will be recorded, and in a few days it will be available in the websites of both FSM and PAHO, as well as in PAHO's YouTube Healthy Aging channel. You will find the links to these sites in the chat, and we'll send you reminders of it later on. We want to make sure the webinar is useful to you, so we have allowed a good amount of time at the end for a session of questions that will be led by Gina Watson. Please use the Q&A function. Remember to write any questions that you have, and Gina will be actually monitoring that, that area to lead us in a conversation with our two presenters at the end of the seminar. Now I would like to ask Gloria Ko, President of FSM, and Enrique Vega, Chief of the Life Course Unit, to open the session with their welcoming remarks. So Gloria first, and then we'll ask Enrique to welcome all of you. Gloria.
Thank you, Martha. It's my pleasure as president of our Association of Former Staff of PAHO to bring you, on behalf of the board and the Healthy Aging Committee, this important webinar on a theme vital to each of us. We consider it especially meaningful during the decade of healthy aging to share information and events in support of our decade. The association extends a special thanks to Dr. Melissa Decardi-Haldeck and Dr. Raphael Samper-Ternant, who have been recognized for their work across the years on the health and well-being of older adults. We are looking forward to your presentation and to the discussion coordinated by AFSM Secretary, Dr. Gina Watson. The association acknowledges the leadership and dedication of Martha Peláez, whose long academic and professional career focused on healthy aging. We are fortunate, Martha, that you accepted our invitation to coordinate our Committee on Healthy Aging. And we look forward to many more enlightening programs. And of course, we are grateful for the collaboration of Dr. Enrique Vega, Chief of PAHO's Healthy Life Course Unit, and Dr. Patricia Morsch, Regional Advisor on Aging and Health. As you can all imagine, we envision the members of the association as one of their priority audiences. Thank you. Enrique, please.
Buenos días y muchas gracias por la invitación y muchas gracias por la oportunidad de...
Good morning, and thank you for this kind invitation. And thank you for giving us an opportunity to contribute to these very important actions aimed and working with the former employees of the Pan American Health Organization in highlighting and developing the decade of healthy aging in the Americas. It's vital that we identify partners and stakeholders working not just within the UN and academic sectors, but also working together with the older adult community, their families, and the community in general. This double standard that allows us to maintain within its membership, not just older adults who have developed throughout their professional careers significant contributions to health in the Americas, to address their needs is vital. And that's why it's so important that we motivate and develop the efforts of the networks with older adults, not just regionally, but also at the individual country level, and in particular in Latin America and the Caribbean, but also North America, including the United States and Canada. So for us, the subject this morning is of vital importance, not only because, as was already described by those who are significant examples in this issue, but also it also touches on some of the fundamental strategic areas during the healthy aging decade. The focus is how we can transform, shape our primary health system in order to better address the needs of older adults. And of course, that would be impossible if we don't consider older adults as part of that, the center. We need to center that, and we need to, around them, they have to be seen as major stakeholders, key players, not only because they are receiving and they are the ones that are going to be showing the healthy outcomes, but also for all of our benefit. So I'd like to thank the panelists, Melissa, Rafael, who are not just renowned figures, globally speaking, in this area, and they're also great friends. But also, I want to thank Gina, who was my boss for many years, and Marta, who wasn't not just my boss, but also my spiritual guide over the last 30 years in addressing the topic of healthy aging. I also want to thank, on behalf of the unit, the Healthy Aging Committee, and all of you for your involvement. And we're very pleased that we have you as partners, and thanks again. Thank you, Enrique. Thank you for those very encouraging words of introduction. Now, it's my pleasure to introduce our two experts this morning, starting with Melissa, Dr. Melissa Hladek. Melissa Maybe you can pronounce your last name, Ladek.
Perdón, pero Melissa
Melissa is a researcher as well as professor at Johns Hopkins University.
School of Public Health, and she's an expert in the topics of self-efficacy and resiliency, both as predictors of healthy aging and function. She will be followed by Dr. Rafael Samper Ternent from the Pontificia Universidad Javeriana in Bogotá, Colombia, where he also did his training in internal medicine and geriatrics. Presently, Rafael is working on several research projects at the Seeley Center on Aging at Texas University Medical Branch in Galveston. And you can find the bios of both of our presenters in our chat. So Melissa, we're so grateful for your time and cannot wait to hear what you are going to share with us today. So take it from here.
Thank you so much for the opportunity to come. Let me go ahead and share my screen. So I am so thrilled and excited to be here today to talk with you about healthy aging, managing stress, understanding your health priorities. And so thank you for the opportunity. And I have no disclosures to report. And, you know, I have this slide up because, as we all know, as Dr. Vega talked about, you know, there's always these large groups of people that are helping us get to where we're going. I have wonderful research teams that work with me on the various projects that I'm leading. I have wonderful mentorship. You may know Dr. Kate Lorig here in the front and center. She has done a lot of work with Tomando de Salud, which is a self-efficacy based program that I'll talk a little bit about in this presentation. So I wanted to start with talking a little bit about what is healthy aging, right? Because we throw these words around all the time, right? So, you know, there's been a lot of change in how we think about what it means to age well, right? So the whole idea of healthy aging started with disease versus no disease. Does someone have a disease or not? And this was prominent even in the 20th century. And basically any other sort of changes that weren't really a disease were just considered normal aging. So, oh, someone has a little bit of a high blood pressure or their sugar's a little bit off. If it wasn't diabetes, then it was just aging. And so this is kind of how we started thinking about aging and how we trained our clinicians in medical school and nursing school as well. And then along came a series of people that were interested in helping to change that definition of what it meant to age well. And the MacArthur Foundation here in the States, in Sweden, they had this very large twin study that was looking at twins over the life course, even starting in the 1800s through well into the 1900s, and looking at, wow, it seems like the environment is also potentially playing a role in the aging process. And so Rowe and Kahn had this very foundational paper in 1987 that really talked about successful aging being more than the absence of disease and more than the maintenance of even functional activities. It was about active engagement in life. And that is a very unique and new sort of perspective. And the problem is that it was still a pretty prescriptive sort of way of thinking about successfully aging. And in fact, using that criteria, the British Longitudinal Survey on Aging and also the Health and Retirement Study here in the US both found that only 12%, 16 to 24% were actually successfully aging in, and I think that if we were to take a poll today of all of us that are over 65, and say, do you think you're successfully aging? I bet you anything more than 1 in 4 would say that they are aging well, right? So the criteria were still a little bit off, and people had some problems with the criteria. So we've been continuously refining what we think it means to age well. And so this is a more recent definition of aging, a state in which a person uses physical and social adaptive strategies to achieve a sense of well-being and high self-assessed quality of life and a sense of personal fulfillment, even in the context of illness and disability. So this is, I think, even getting so much further even about defining our way of aging and being healthy, taking it even out of the context of chronic disease, right? It's all about our perception of how we're doing. So other terms have emerged besides successful aging. That's why I titled this talk partly Healthy Aging, right? So balanced aging, resilient aging, harmonious aging, because the simple fact is that most older adults do have at least 2 chronic diseases, right? So, and you can still age well with chronic disease. So this is kind of the history of what's been going on. And I wanted to ask my own dad about this. This is my dad, Pedro, and he's from Puerto Rico, and he immigrated to the States when he was a child. And he said that aging successfully to him meant participating in outdoor activities like walking to the town center. He's not there yet. He has a lot of arthritis, and having like-minded community. And in my case, able to play music and play with hobbies and following scientific discoveries with discussion. So I love this because I think it's okay for us to also think, well, what does it mean for me to age well? And that's kind of ultimately what this talk is all about, is how do I find out what my values are, what my priorities are, and how do I communicate that well to my healthcare provider and to my family in order for me to live the richest and the most highest quality of life according to my values. So I love what my dad said here. So I think another piece of the puzzle is that healthy aging really looks different for different people and different levels of exposure to stressors. This is ultimately why I went back to school after being a clinician for almost a decade. And I went back to get my PhD because I really saw that this lifetime cumulative stress burden that we all can have to various degrees, and the continued disease burden and progression that we all have, really ended up creating very different outcomes in aging for people. And really a lot of differences in what aging can look like. And really here, this is a nice slide looking at how different the trajectories of aging and disability can be. You know, when we're young, we all everybody has the same benchmarks. Are you taking a steps? Are you walking? Is the baby talking yet? Is the baby saying a couple words? It's very rote. It's for any baby, it's the same. But as we age, the trajectory of successful aging and disability really gets very wide and changes based on our cumulative stress burden in the way that I think about it. So ultimately, when we think about healthy aging, we really want to maintain high levels of energy, good health, living independently, clear thinking, enjoying social contact and meaningful activities. This is a picture of my family, my grandmother Nilda, my grandfather Pedro, and many other family members. Here remember when we all had, before smartphones, when we had cameras and you could set it up and take a picture and then wait, we couldn't figure it out. And so we kept on messing it up. So this is us having a great time. But what older adults want to avoid is really anything catastrophic, anything, post-surgery, a very bad outcome, very bad health. We want to avoid functional dependence, having to not be able to, have problems with walking, and dementia, of course, and isolation, lack of meaningful engagement. These are things that generally we want to avoid. This is my Titi Aida in Puerto Rico. So how do we get there, right? How do we get there? What are some ways that we can get there? And I really love this Aesop's Fable. I'm sure that a lot of us are familiar with this Aesop's Fable of the oak and the reed. And I won't read the whole story to you here, but basically the oak and the reed are friends, and a big giant storm comes and the tree ends up being uprooted. And the tree asks the reeds, why were you able to stay in the ground and thrive when I, this big, strong tree, was not? And the reeds say, you were stubborn, came the reply. This is the third paragraph down. And fought against the storm, which proved stronger than you. But we bow and yield to every breeze, and thus the gale passed harmlessly over our heads. And I love this idea of adaptation, right? This whole idea of how do we adapt to the changes that come with aging, right? And that can be one of the ways that we mark success or healthy aging as well. And I love this slide too, because it talks about resilience, which is kind of what we just talked about with Aesop's Fable. Resilience can look very different based on the stressor and the person and the context, including their family structures and all the different environmental contexts that we live in. And I think each of us can think of a family member or a friend or colleague or a patient that's demonstrated each of these trajectories. So you could think of this bottom line here as time, and the top line is performance. And so say, for example, someone has surgery, right? A knee replacement surgery, for example, and for a while in their time horizon, they're not performing as well because of that knee replacement surgery. But then as time goes on, they're able to bounce back up and function well. They may even, on number C here, or letter C, they may actually improve their function because their knee doesn't hurt as well anymore. There's also the idea that their function doesn't change at all. They just absorb the stressor, which I'm not sure if that's even possible in the context of humans. The whole idea that the body does keep score, and we may have something underneath the skin, like changes in inflammation that are taking place because of that. There can be just a slow degradation of ability. And then there's also this idea of a little bit of change in function. And then there's the F here is things are really not doing well post knee replacement surgery, and the person is really struggling to recover well. So I think the other thing I wanted to mention with resilience is that you can think of resilience as psychological, like, you know, the ability to recover from the loss of a loved one, which is a very, very heavy psychological burden to carry and to recover from. And same thing with physical, like you can, like, recovery from a surgery. So there's a lot of different ways that you can think about the idea of resilience. But one really big part of resilience, this adaptation as we age, is self-efficacy. And self-efficacy is the belief or confidence someone has in their ability to accomplish a specific task or behavior. It's action-based, and even in the face of adversity, with the idea that we can take control of our lives where we can. And so I think this construct is very, very important to healthy aging. This is me, this picture is me here with Dr. Albert Bandura. He is the author and the genesis of the concept of self-efficacy and social cognitive theory, which has very much influenced a lot of the way we do health behavior change in our society in general. He recently passed away in his mid-90s, lived a very long life and touched a lot of people. And I was lucky to have a couple days with him as well. So how do we develop self-efficacy? I think this is really important to aging well. Like how can we change this? How can we adapt and change our self-efficacy? Because self-efficacy is changeable. I think there are 4 distinct ways that we can do this. The first being this enactive mastery. And with older adults we all have a lifetime of experience to pull from, right? And so I've had patients that have lived through civil war, homelessness, violence, great personal and familial loss, and yet somehow they've made it through and continued to pursue their own health and mastery and wellness. So, you know, we can use those experiences that we've had success in to help us do well in other contexts as well. So another way that we can gain self-efficacy is by looking at how other people have tackled problems. So this one involves our social support. If we have people in our lives that we've seen do really wonderful things, we can then look to them as inspiration. Wow, this person, my sister was able to do this. Maybe I can do it too because they were. Another one is through verbal persuasion or coaching. We can have people in our lives that say, you know what, why don't you come join me in my swimming aerobics class, or come join me on this walk. I think you can do it. And we then are able to say, wow, I wonder if he thought I could do it, then maybe I really can do it. And so that's another way that we can gain self-efficacy as well. And then the last way is even through our own physiologic processes. And with self-efficacy theory, this particular one, this physiologic feedback, sometimes is not given enough priority, I think. But basically, you know, when you go into an event where you're a little nervous and your heart's pounding and you're sweating a little bit, that's your body telling you, I'm struggling with my own confidence and my ability to do this. And we can listen to that and say, oh, wow, this is a little bit of a harder situation. Or we can say, oh, no, I have this in the bag. I can do this, no problem. And that's the physiologic feedback that our body gives us in order to tell us more about how we're feeling, how confident we are about a particular task or domain in our lives. So the thing I really like about self-efficacy is it doesn't matter how old someone is, right? You can always change your self-efficacy in various domains of your life. So someone says, you know, I've never been someone who exercises a lot, and actually I hate exercise. That doesn't mean that that has to be the same for all of time. It doesn't mean that that needs to be the case until someone dies. People can change. And so I love that about self-efficacy is it doesn't stay static. And there's kind of these direct and indirect effects of self-efficacy. So one of the indirect ways that self-efficacy works on our own ability to age well is through behavior, right? So our self-efficacy then, in fact, is nestled within this social cognitive theory that basically allows us to change our behavior. And there's a really strong link in the research between self-efficacy and health behavior change and maintenance in the face of adversity, that resilience piece. So if someone has very high self-efficacy for exercise, for example, then even if it's raining outside, even if they have very limited time, even if they don't have the money for a gym membership, they're going to find a way to exercise. And so that is that's all of what we want. So behavior change can be greatly influenced by someone's self-efficacy. There's a couple of great programs. Here's Dr. Kate Lorig again. This is this program is international, this self-management program. And in Central and South America, it's called Tomando Control de su Salud. And here in Maryland, it's called Living Well. And this program is all about improving someone's self-efficacy so that they can achieve their health goals and age well. And Dr. Sarah Zanton, who is my mentor, she's the dean at the School of Nursing and just a wonderful person. She recently won the Heinz Foundation Award, which is a very high honor. She actually created a program called Capable, which is a wonderful program using a handy worker and a nurse and occupational therapist to make someone's home more successful for aging, putting handrails, changing lighting, making the home safe so that someone can live there longer. It's a wonderful program, and I think we'll talk more about it at a future PAHO event. Both of these, though, are self-efficacy based, and they all act on self-efficacy to change behavior as well. So like I said, there's also this other aspect of self-efficacy, the direct effect. This is what a lot of my initial research has been about at Johns Hopkins. So this really involves stress perception. So as you're all aware, perceiving something as stressful really involves a two-step process. Assessing, first we assess it. This is stressful. It's a threat assessment, and we think, gosh, this is a stressful event. And that is influenced a lot by one's environment, right? By context, by socioeconomics, culture, any discrimination, community issues, and someone's stress burden, right? I think we all can recognize this in the midst of COVID, that just one thing after another piling on with these stressors makes it harder to manage the stress burden. But there's a second part of the stress assessment, and that's, now that I know I've assessed something as stressful, can I handle it? And that's where self-efficacy comes in, because we decide, gosh, this is stressful, but I have the internal resources to handle it. And that's going to be influenced by our own self-efficacy for whatever stressor that is, as well as our social network, which certainly influences our self-efficacy as well. Do I have the confidence in my own capabilities to confront this stressor? And then if there is a mismatch, though, between what a person thinks or feels that they can handle and their original threat assessment, the body's stress response network kicks into gear. And this is where we have this stress response network inside the body. And this is where I do some of my research. And certainly if those pathways of stress response are activated chronically over time, this actually leads to some of the ways that aging trajectories can change for people, and leads to greater chronic disease progression, some of the aging biology that we talk about, as well as a large other set of changes. So how does self-efficacy, what is the research? I'm not going to spend a lot of time getting into the research of self-efficacy and the biology of aging. I just want to show one study that I think is a good representation. This graph shows the relationship between caregiver stress, that psychological overload on the bottom, and something called plasma IL-6. IL-6 is also called interleukin-6. It is a cytokine, which is kind of a protein that talks to various parts of the immune system to create more inflammation. Inflammation is good in the short term. When you have a cut on your hand, for example, we want the inflammation to bring all the needed things to heal the cut. But over time, inflammation can become chronic and can lead to poorer health outcomes. So what we saw, and this isn't my study, I've done some of this work too, but what we've saw, and what this study showed, is that when self-efficacy was low, overload, the psychological overload, was significantly related to IL-6. But when self-efficacy was high, however, overload was not significantly related to IL-6. And so in this study, the authors hypothesized that high self-efficacy might be playing more of a protective or buffering role against high IL-6 in the presence of increased stress. So I think that this fits very well with what I was talking about the threat of stress and the can I handle it part. So how do we improve self-efficacy and resilience to cope with stress, right? That is the big question, right? And in order for us to age successfully, to age healthily. And, I think there's a lot of people asking about this, right? So one, I would say the ICOPE, the WHO's ICOPE with the focus on intrinsic capacity is one of the really excellent ways that this is trying to be operationalized in healthcare systems. This 4Ms framework, and I think there's even a 5Ms framework that Dr. Samper-Turnet will talk about, where we talk about, well, what matters to people, right? As well as their medications, their cognitive function, and their mobility. We're starting to realize how people perceive things and what matters to them is actually just as important, if not more important, than all the healthcare for their diseases that we could come up with. So that is what takes us to the final part of our presentation today, and that's how to get what matters most from your healthcare, right? And so I just want to take a mention that these slides were, the upcoming slides were adapted by Dr. Mary Tonetti. She's out of Yale. She's the chief of geriatrics. I work with her on a grant looking to promote patient priorities care, which is kind of a systematic way of helping both patients and clinicians learn how to really take what matters most to patients to heart in decision-making about their healthcare. So it's very exciting because it puts the patient at the center of the healthcare team, and that is always a good thing. So let's go ahead and meet Mr. Sanchez. So he is a 77-year-old male. He has 3 children, 5 grandchildren, 1 wife. He has 6 chronic diseases. He's on 9 medications. He sees 5 different clinicians, and he has 1 visit per week. Every week he has to find half a day to go get labs done or go to the doctor. So he has a lot of medical problems going on, or go to physical therapy or something. So, okay, from the clinician perspective for Mr. Smith, people would say, oh man, his blood pressure is too high, his sugar is too high, and really he needs a hip replacement because he's just walking hard. But the orthopedist and his primary care provider feel like a little different about should he really get that hip replacement given his age and the other medical problems that he has. So Mr. Smith, even though those numbers that the clinicians are interested in are very important, for Mr. Smith, for Mr. Sanchez, he's always tired. That's what matters to him. He feels tired all the time. He's spending too much time on his healthcare. He doesn't want to be going to appointments all the time and changing his life around that. And he doesn't drive as much anymore. And so it's always a challenge to figure out who's going to take him to these appointments. And he's just not sure about the surgery either. So when we talk about this healthcare for persons with multiple chronic conditions, we need to think about, a lot of the guidance that we have about who should be getting this surgery or who should be getting this medication is based on people that are a little bit younger, maybe 70 and younger, 65 and younger, because those are the ones that were included in the original evidence-based randomized controlled trials for this medicine, or they may not have had so many chronic conditions. They were excluded from the trial because of their chronic conditions. But now we're trying to apply those same evidence-based those guidelines to people that have all these medical conditions, right? And so how do we do that? So when we think about someone like Mr. Sanchez, we're not sure about the benefits. Like, is it good that he's on all these medications when he's very tired all the time, and the burden of it all? So I think so what's the answer to when you have multiple medical conditions and you're really trying to be healthy, but you feel tired all the time and you think some of the healthcare isn't really helping? What's the answer? So I think the answer is that it's important to explore your own values, right? What matters most to you? Is being tired the thing that matters most to you, that you want to work on, that you want to have more energy? At the same time, though, we have to be realistic with what's possible. So when we think about health goals and what people are willing to do, right? This is the impossible trade-off, the impossible triangle of trade-offs. So people want to live longer. People also want to improve their functional status. And then there's also the relieving of symptoms, but sometimes it's hard to do all of them. It might mean that living longer means that you have to take this medicine that actually makes you feel a little tired, and the tiredness is what's making it hardest. So it's a challenging set of goals. But I think what we would say in patient priorities care is that the answer is to know what health goals you most want, given what you are willing and able to do. And that's, I think, that's the gold in the midst of this as we age, right? And there's no right answer here. There's no right answer. It's just what's right for you. So I think with patient priorities care, we would say that the decision making isn't, well, you need to do this. For this, you need to, take all of this diabetes medicine for your diabetes. Instead, what we would say is, I suggest as a clinician, we try this, knowing your conditions, your overall health, and your goals and preferences. It's all about shared decision making, your provider and you working together. So how do we get to identifying our health priorities, right? That's kind of what we're going to talk a little bit about right now. So in general, there are 4 broad domains of values that are relevant to older patients. And the first one is about connecting, right? Connecting with friends and family and community. This might include church and going to church and going to mosque or temple. Another key domain is really enjoying life, which includes things like recreation and hobbies, personal growth, being able to be productive. Another one would be managing your health, like managing those symptoms and quality of life. And patients often vary in terms of how they'll balance improving quality of life versus extending their life, and which symptoms they want to manage most, right? Everybody's a little different. I can live with that knee pain, but I cannot live with this fatigue, for example. The 4th domain is really about functioning, and this is often a really important area for patients with multiple chronic conditions, because it really relates to being independent. Like, do you want to be able to live in your own home? Is that the highest value? And also, patients vary in their willingness to receive assistance and their desire to maintain their dignity. I do not want help as long as I possibly can, for example, or I'm okay with help. I want to be able to stay in my home with help for longer. So this is the time where I just ask you to reflect briefly, and I know we're getting over time a little bit, so I'm just going to say, what matters to you, right? Is it connection? Is it enjoying life? Is it functioning and managing health? And it could be a whole compilation of all of these things too. So then the next step, once you kind of have a sense of, these are my values, this is what matters to me, then you can funnel that down a little bit more into, what is the one thing that is most important to you? What is that one guiding thing, that this value, this one thing that is very important? And so what that leads to then is health outcome goals. So the step 2 is getting to specific, actionable, and realistic goals that are meaningful, that are linked to your values, right? So if your value is to live at home for as long as possible, then maybe the actionable item is, I need to take a walk every day, no matter what, so that I can stay functionally fit, so that I can live at home as long as possible. So what does that mean? To put that, to be specific about it, to say, I'm going to do this 30 minutes. And also, is this realistic? Oh, I just had a hip replacement. Well, I can't be doing my walking right now. So what else could I be doing to help with my main goal, my most important goal? And oh, this slide got a little bit lost here. Okay, so there we go. I think what this slide is telling is the difference between being specific and being realistic, right? So in this case with exercise, I want to be healthier. That's a wonderful value, but how do you make that specific and realistic, right? It's very realistic, but it's not specific enough. Whereas starting this week, I'll watch my grandchildren after school 2 to 3 times per week. That's both specific and depending on someone's ability to function well, it's realistic or not, right? For different people, it'll be different. I will start jogging a mile every day before breakfast. It's very specific, but perhaps for someone who hasn't even been walking, jogging a mile is not realistic, right? So you see kind of how these two play together to create a good goal that has to do with your values. So here are some other examples of outcome goal examples. I want to babysit and play with my grandson. I want to be able to work a half a day at my office. And you'll notice here they say doctor visits interfere with that. And then here's another one, do ceramics and walk half a mile with my husband. And there's the tiredness that makes this difficult. So what I would say too is that we then need to see which healthcare preferences are going to match up with your values and your goals. So there's medications, there's healthcare visits, there's testings, there's all the self-management activities that someone can do, right? So what examples here would be, I get blood work every month, and that's not bad. I can do that. My CPAP for obstructive sleep apnea, that really helps. I can keep doing that. My Pepsid that I take, it helps with my heartburn. I like that. I walk and do exercises that PT taught me every day, and that's doable. But sometimes there's also things that can be harder for people. So for example, my medications cause my muscles pain, and then it's hard to be active. Those sorts of things are really important to communicate to your provider, because perhaps there's a way that could be changed or lessened, or maybe it's about the trade-offs that we talked about. Maybe taking that medicine extends your life, but you also have this side effect, and is it worth living with that side effect in order to extend life, right? So these are the trade-offs we're talking about. I get hypoglycemic and shaky, like a low blood sugar. I'm taking too much of something. So one of the medicines for diabetes is causing the shakiness, and that needs to be communicated to the healthcare provider. Insulin and glucose checks are too often. I don't like doing this. That's really good to know. And I don't want back surgery. So those are examples of healthcare that's really not helping, or it's not working as well. So back to Mr. Sanchez. I want his goals. I want to be less tired so I can get to the club a few days a week, and my medications make me too tired. And he says, I can live with the hip pain and I don't want surgery. So his health outcome goal becomes, I want to get to the club 3 times a week. And his healthcare preferences are really that he could decrease this medicine and avoid surgery. So these are the things that we can take to our provider. And I know that Dr. Semperturnet, I'm saying that wrong, lo siento, is going to be talking a little bit more about talking with our healthcare provider. So I think I'm going to go ahead and leave it there. I'm a little bit over time. So let me go ahead and stop sharing my screen and turn it over to Dr. Semperturnet.
Thank you, Melissa. That was great. I don't think I have much to say after that, but I'll try. Okay, so let me share my screen. And for the future, Melissa, I think we should do patient priorities care always as a team. It works a lot better. You take the hard part and I take the easy part. How about that? Sounds like a great collaboration.
Sounds great.
Okay. So is everyone seeing my screen? Yes?
Yes.
Okay. So thanks to Martha, Enrique, and all the organizers, and Melissa for inviting me to be part of this great session. And as Melissa mentioned, I'm going to go into more depth on the second part of patient priorities care, which, as Melissa mentioned, is an approach that was designed and tested to improve outcomes in persons with multiple chronic conditions by putting at the center of the evaluation and the management what matters most to them. Okay. So let me start a little bit as a geriatrician, and I'm going to use geriatrician loosely here because Melissa and her colleagues also do this very well. So geriatricians here is intended to talk about clinicians that take care of older adults. And what matters most to older adults has been at the core of what geriatricians do since geriatrics became a subspecialty in the United Kingdom. And so this is not new for us, but unfortunately, as Dr. Tinetti mentioned in 2017, when she came up with the 5 M's of geriatrics and has continued to support through the last several years, we haven't done a great job in how to structure this and how to empower patients to actually do this, to actually share with clinicians what matters most to them, and to actually get clinicians to get on board with what matters most to them and work on a plan of care that actually reflects that. So this is where patient priorities care, I believe, has made a huge difference, because it's a structured way that clinicians can use to actually get to what matters most to patients. So Melissa mentioned this briefly. So the Institute IHI uses the 4M model. Geriatrics as a discipline tends to fall back on the 5 M's. The only difference is where multi-complexity falls. For the IHI, it's inherent to managing older adults in the hospital. For geriatrics, we added because it's easy to remember a hand with 5 fingers and think about 5 things that you need to focus when you're training to care for older adults. So what matters most is what patient priorities care focuses on the most, but it also considers mind, multi-complexity, like Melissa mentioned, medications, and mobility. And so this is a quick way to remember when you're going to see your doctor next time to bring this hand and think about those 5 things. And as long as you feel that those 5 things are being addressed in one way or the other, then you're in great shape. So Melissa mentioned this. So patient priorities care, or PPC for short, has 2 steps. I'm going to focus on the second step because Melissa did a great job talking about the identification of health priorities. I'm going to focus more on the care alignment piece of PPC. And what the care alignment means is considering if the current medications, if the current doctor's visits, if the current lab work, x-rays, everything that is being prescribed to you is consistent with your outcome goals and the one thing that matters most to you. And is it consistent with your care preferences? And so I hear a lot, but why one thing? When you have multiple chronic conditions, you can't focus on just one thing. I agree, but we need to start with one thing to make sure that we're addressing things in a structured and efficient and effective way. So as I'll show a little later, this doesn't mean that it's the only thing that we're going to focus, but it's better, at least in my experience, to tackle one thing at a time. And then you do trials, you make sure it works, and then you focus on the second thing, and then the third thing, and then the fourth thing, until we get to where we want to be. So this is an iterative process. It's not a one thing where you come see me once and I fixed everything and now your care is aligned with your goals and preferences. This is a construction where the clinician, the patient, and the family set up a plan and try to follow the plan and try to get as far as they can by following the wishes of the person with multiple chronic conditions. And at the center of the second step of PPC is focusing on communication with the patient. There's going to be trial and error, and so people get really scared, especially when you're talking to an academic audience. It's like trial and error is against everything we've been taught, it's against all the guidelines, it's against, well, yes, but as Melissa mentioned, no 93-year-olds with multiple chronic conditions were included in any of the clinical trials that we're currently using to prescribe medication A or lab B or cholesterol levels or whatever you want to use as the outcome. They were not included there. So it's okay to do trials as long as they're safe and they keep in mind what matters most to the patient. It's okay to do trials and see what works, and what doesn't, you can always change. And finally, prioritize care decisions, especially when there are different perspectives involved, and I'll touch on that a little later. Okay, so when we think about alignment, Melissa mentioned someone already, when you're going to see your PCP, someone has already done some work with you to identify what your goals and preferences are. So that's usually hard for the patient, because until now they've never been asked by anyone, so what are your goals and what are your preferences? So that takes some time to discuss and to identify what matters most to you. But then once that work is done, then there are two additional things that need to happen. First, the clinician needs to go over those goals and preferences and then decide, okay, of the current treatment that you're getting, medications, lab work, doctor's visits, anything related to your healthcare, what is helping you and what is aligned with you and what isn't, and what is hurting you or potentially not the best treatment because it's not aligned with what you want. And then once that review has been done, so as you can see, this requires some work from the primary care provider or the clinician taking care of you, then it's okay, now that I know what your goals and preferences are, let's make sure that all that we're doing is aligned with those goals and preferences. So some people say this is part of the same step. I like to think about it in two steps because it actually forces you to consider and decide what you think you need to change, and then start the trials to make sure that the changes that you're making are aligned with the patient preferences or the patient priorities. And as the picture shows, it's teamwork. This is not the primary care provider working alone. This is not the patient just saying, this is what I want and it'll happen overnight. This is joint work. So as you can imagine, when we're talking about novel models of care, and Enrique probably can tell you, and Martha as well can tell you how hard it is to get people to buy into new models of care. There are a lot of challenges that we need to overcome. I think what makes PPC different is that we're trying to overcome challenges to focus on what matters most to the people receiving the care. And till now, that has not been the main focus of most models of care that we've implemented. So there are challenges for the patient and the family, and there are challenges for the clinicians as well. So the reason why I put this table here is because there's going to be a lot of work that is required from both sides to get to this, and that's fine. But this needs to be a collaborative effort to be successful. And so for patients, it implies a paradigm shift. Hispanic older adults especially, but most older adults have been told since they grew up that the doctor knows better. And so we just need to tell them what we're feeling and follow the instructions that they produce based on their knowledge. This requires a total paradigm shift because I'm not telling you what I know, I'm asking you what's important to you. And based on what's important to you, then we'll create a plan of care together that we'll try to implement and successfully complete. So that requires a change in how you perceive going to the doctor, because it's not just bringing your brown bag with pills and telling them how your blood pressure has been or your blood sugar. It's telling them, I don't really measure my blood sugar anymore because it's not important for me to know what that level is because X, Y, and Z. Or I didn't bring my medications because I stopped all of them because they were making me sick. So I want to work on just using the ones that are absolutely necessary. I don't care if I die tomorrow, but I just want to be focusing on what's really important to me, that is to spend time with my wife walking on the beach, whatever it is. Then the other challenge is that you need to think hard and look inside and say, what is really important to me? Making the doctor happy is not important to me. Making the nurse practitioner happy is not important to me. Spending time with my grandchildren is important to me. And so that requires a clear, thoughtful process where you actually identify what are your goals so we can work with you to get to those goals. There are trade-offs. And so we need to be clear that there are going to be trade-offs, and we need to agree that we're willing to take those trade-offs because we're focusing on what matters most to each patient. And some people have some trade-offs that they're willing to accept. Others have other different ones. So like Melissa said, there is no right or wrong answer. It's your answer. And your answer could change. So you could try and say, you know what? I'm willing not to take the diuretic that makes me go pee every 30 minutes because it's so annoying and I can't leave the house. But then you stop taking it and you start swelling or feeling short of breath, and you say, you know what? I can't stop it. Can we try a lower dose? And we can do that. So it depends on each individual goals. And finally, it needs patients to be empowered to be able to discuss what's important to them. And that is the clinician's responsibility, but it's also your responsibility as a patient to feel that you need to get in the driver's seat and drive how you want your health to be helping you and to be by your side as you live your life. And that seems easy, but it actually takes some work, okay? So on the other column, we have the challenges for clinicians. And so there's a lot of uncertainty. And clinicians, like older adults, we've been trained in a certain way, and we've been told that guidelines, because they're evidence-based, is the way that we should be practicing medicine. But when we take into account the complications and the issues related to following guidelines on people with multiple chronic conditions, then it's okay to not follow the guidelines to address the priorities of the patients and how they want to live their life and how they want their healthcare team to provide services and support to them. And there are different perspectives. And so this is a big issue. The more specialized we've become in medicine, the cardiologist takes care of the heart, the neurologist takes care of the brain, gastroenterologist takes care of the gut. And so it's a very fragmented model of care that makes it really hard to sit, discuss, and make changes. But it's part of a process that we as clinicians need to take to be able to align the care that we're providing to our patients with their priorities and goals. So it requires taking the time and sharing with a colleague and saying, you know what, Ms. Jones is taking metoprolol, and I know that that will decrease her mortality, but she doesn't want it because it makes her weak, and all she wants to do is to be able to go visit her grandchildren, even if she dies tomorrow or the day after that. And so it requires sitting down with a cardiologist and saying, I know why you're doing this, but this is not what Ms. Jones has. Can we agree on something? And then the cardiologist says, okay, let's cut the dose in half. And for 2 weeks, see how that goes. If that doesn't make a change, then we can stop it altogether. So that's what it takes. And it requires additional time that the current models of care probably won't allow, but we need to find a way to get that time and get that process underway. So there's some strategies for alignment that we need to keep in mind. And again, this is also adapted from the work that Dr. Tonetti, Dr. Nayak and Dr. Blaum have been doing with patient priorities care. And so one of the key strategies for alignment is we make the patient priorities the center of our conversation. And there's a geriatrician in New York that has put this in, Claire Davenport. She's an amazing PPC champion. And she's done a lot of work on how to actually make PPC the center of her practice. And she starts every communication and every note by saying, based on Miss Jones' priorities, which are visiting her grandkids twice a week or going to the library and volunteering or whatever that is. We've discussed her health over the last 4 weeks. She feels better, less short of breath or whatever. And based on that, we think it's a better idea to continue lowering the dose of the metoprolol and getting there, whatever. And so when a cardiologist sees that note that starts with the heading based on Miss Jones' priorities, it's not based on the guidelines, it's based on what she wants, then the conversation changes. So putting the priorities at the center of the conversation and the care is a great strategy to actually get things aligned well. As I mentioned, there are serial trials, so this is not one thing that I sent you out the door with a new plan and tomorrow you're going to be better. This requires joint work, it requires follow-ups, it requires calls every now and then and say, is it normal for me to feel this way after I stop the metoprolol? Is it okay? So it requires team. As a clinician, I can't do this on my own. There's a team and the team needs to work together for the trials to work and for us to get to where we want to be. And finally, it requires sitting down with the clinicians and making decisions. And so as a primary care provider, I have to agree that sometimes we won't be able to get as far as I would like to, but there is a negotiation and we agree on what we think it's best for the patient based on their priorities, and we take it from there. Okay, so communication is key for all of this to work. And so good communication has been shown to make care plans work. So patients that actually sit down with a healthcare provider and discuss the plan of care and ask questions and understand what the plan of care entails do better overall. But it's a two-way street. So the clinicians need to make an effort to actually explain what they're writing and how they're going to make it happen. But patients, you also need to ask questions. You also need to say, no, that's not my priority. My priority is actually this. Or no, I didn't say the metoprolol was bad for me. I only think that I'm taking too many pills. And so I was questioning if metoprolol was the best option. Because most patients, when they get a prescription saying DC, which is discontinue metoprolol by half for 2 days and then stop completely, they take it, they thank the doctor and they leave. But if that's not what you wanted, or it's not clear to you why those changes are being made, unless you ask us the question, there's no way for us to know that that's a question and that's an issue and that we need to fix it. So some tips on how to do this. So you need to talk openly. As I said, you need to sit down in the driver's seat and drive your healthcare. And so how does that happen? So you share your goals and your preferences on every visit. And part of the materials that we have with patient priorities care is actually a sheet that documents what your goals and preferences are. And so that needs to be inside your brown bag with your medications, and you need to bring both to every doctor's visit, because people need to understand what your goals and preferences are so they can make adjustments to meet those goals. You need to ask for help, and calling a clinician and saying, you know what, I can't keep up with all my medications. I need a pill box. I need you to write them in a different way. I need you to talk to my daughter and explain so she can help me. That requires some strength and it requires some empowering, but no one else but you can tell us what you need help with. And so unless you are loud in stating what you need help with, we can't do our job. Third, you need to ask questions, and I can't enforce that enough unless there are questions. And if the clinician that you're seeing is not willing or able to answer your questions, then you need to find someone else that can, and that's okay. And you need to be specific. So Melissa talked about the goals, and goals that are specific are easier to accomplish, and they're also easier to track. So I want to be healthy. Okay, that's good, but that's not specific. How do you want to be healthy? What are you willing to do to be healthy? What trade-offs are you willing to go over? So the more specific, the easier it is for us to make changes and get to the goals and address the priorities that you want to get. And I can't emphasize this enough, writing is a great tool. So the little notebook where you document the itchiness that was caused by the medication, or the swelling on the right cheek after putting cream, or whatever. Make notes, because when you get to the doctor, we always make the same joke. Oh, as soon as I leave here, I'm going to have all the questions. Well, if you write them down, then we can address the ones that you've been gathering over the past month. And then you start writing again for the next visit. And so that makes it easier for everyone to know things that are bothering you that we need to fix. So how to talk to your healthcare team. So in a system where we've been taught that patients listen and obey what the doctors say, and doctors have been taught to follow guidelines because that's your best option for providing the best care, then communication has been lost in many ways. And so these are just some starters that you can use, but they're in the Patient Priorities Care website. There are other materials that you can use, but making the shift in your head that the conversation starts with, now that you understand what's important to me, can we work in a solution that will allow me to visit my grandkids twice a year or twice a week? I really don't like this because it makes me feel dizzy. Can we find an alternative? What concerns me the most is that I'm going to be a burden to my family. My main priority is making sure that I can walk to the park 3 times a week and walk my dog. Even if it is uncomfortable, I'm willing to take my blood sugar once a day if it helps me not get into the hospital or go to the emergency room. So those are things you're thinking, you're shifting how you're addressing this. And it's like you're waiting for the doctor to ask you how you're doing, to I'm telling him what is bothering me and how I would like him to travel with me in the health journey and get things done in a different way. Okay, so Melissa touched on this, and I want to reinforce this. This is an adaptation process, so things are going to change, and your priorities are going to change. So your priority could be walking my dog every day at the park, and then you fall and fracture your hip. And so maybe that's not an option. Maybe you want to go while you recover on a wheelchair or a walker while your daughter walks the dog, or watching from the window while your daughter walks the dog, or things can change. And then once you're recovering and doing well, we can go back to the original one. So we both, clinicians and patients, need to be flexible and understand that life happens and that we need to adapt to the changes that life brings. And I'll stop there and see if there are questions.
Thank you, Rafael. I think we have been getting a few questions, and Gina is going to take it from here. Dr. Gina Watson is going to actually lead the conversation. So take it from here, Gina. We have about 15 minutes, and we'll have the concluding remarks for 1 minute at the end with Patricia.
Thank you very much, Marta. Can you hear me?
Yes.
Okay. Thank you very much, Dr. Khaled. I hope I said that well, Dr. Samper, for your very enlightening and thought-inducing presentations. You have provided us with a lot of food for thought, particularly in many cases, and I will address that in some of the 2 or 3 questions that we have. First, I would like to say that aging is a process, as you said yourself, a complex process that involves also at some moment even denial of accepting the fact that I'm now retired, I'm growing old, and I have other problems to take care of. And one of the observations from our colleagues, and we have many in the forum at this moment, addresses the situation of taking care of oneself and others. And I want to thank Melissa for the beautiful photos with her father. Many of us take care of our parents. I have a 97-year-old mother that I take care of, because in our countries, we do not put our old people in facilities. We take care of them at home. So some of these challenges in facing one's own reality on the other of the second or third person on their responsibility certainly leads to thought on the elements that you have shared with us with the 4 or 5 M's that are very important. I would like to have your perspective on this in regards to what self-care and sharing care, providing care. The other question that was put forward also, and I'm going to give you all the questions, the 3 that we have at this moment for, refers to the situation of what happens if my clinician refuses to make changes in my care plan to fit my priorities. And we mention this because we live in a variety of countries where access to care and facilities to ensure quality of life differs greatly in our health systems that are also very different between South, Central, and North America. So I would appreciate your response to this. The next question that relates to this shift in the paradigm in regards to the communication, patient and clinician communication, and how this relates to taking control of one's health and making decisions, even though there may be sometimes conflicting positions with the caregivers. There's a question that was placed in Spanish, and I'm going to put it forward in the same way. La alimentación debe considerarse como
food and nutrition is important in aging.
Melissa's consideration on this. Last but not least, the least, is what advice involves a person in early dementia controlled by his children who are not allowing him to exercise his preferences, as they control particularly only physical issues. We would appreciate very much your consideration on these topics. Thank you.
Thank you so much, Dr. Watson, for moderating the. I'll talk about the alimentación real quick. I think that one was for me. Yeah, absolutely. I'll answer in English only so that translating, Martha told me answering in one language is best. But so with nutrition, absolutely, it's so important and so key to self-management. And as we all know, 99% of the time, life does not involve healthcare providers, right? Life involves living outside of the clinic, right? So self-management is the most important tool that we have as people, right? And diet is a huge part of self-management. The big question from a patient priorities perspective is, how much change are you willing to do, right? So, you know, when you're 90 years old and you love having ice cream every day, you know, is giving up the ice cream with your diabetes worth it or not? And no one can say what's right except for you, right? And I think that can be hard too for caregivers. Dr. Watson, you mentioned being a caregiver. I know I'm a caregiver, and some of the priorities that my parents have are different from my priorities for them. And so as Dr. Samper-Turnet was telling us about the clinician and the patient, sometimes I think that applies to the caregiver and the patient too. And how do we respect our older adults that we care for? That need for that piece of apple pie and ice cream every day, period. I'll do all the other things, but I want my ice cream. Like, so how do you handle that? And I think ultimately it comes down to the trade-offs conversation. It's okay if you want to have that scoop of ice cream, but we all need to understand what that means too. And so I think that that's how I talk with people and patients about diet. Is there are no right answers, but it's how do we make small changes that are acceptable over time.
Thank you, Melissa. Dr. Samper, please feel free to question or comment on any of the other topics that our colleagues have raised.
Okay. So I maybe will touch on two parts of it. So one is caregiver self-care. And that's also a huge issue. A lot of my work now focuses on dementia. And so caregiver exclusion from the model has been horrible, has done a huge disservice to families providing care to older adults with dementia, because the specialist or the expert in dementia usually only uses the family or the caregiver as a source of information, but they neglect to look at the needs that they have. And so we're losing half of the story. When you have a person with dementia and you don't address the issues that are affecting the caregiver, you're missing half the story. Because eventually that caregiver is going to end up in the hospital, and then who's going to take care of the person with dementia? And so you end up having two patients instead of one. What's the right answer? We need new models of care where you can actually see both the patient and the caregiver in the same visit. And in geriatrics, in some institutions, we have the advantage that we're allowed a little more time to see older adults and their families, but it still requires extra work that is not included in the schedules, is not included in the reimbursements, it's not included anywhere. But that's the right thing to do. So we need to find a way to do it. So self-care is definitely one of the things that we should be telling all caregivers to do. And Melissa brought up a good point. The caregiver's priorities for the person that they're caring for might be very different to their own priorities. And so it requires communication. You actually need to sit with your daughter and say, I know you want me to live forever, but I'm not going to. And so I'm willing to take my apple pie and ice cream every day, even if my blood sugar goes to 300, because that's what I like. And the daughter may not want that, may not want to hear that, but at least if it's out there and it's been discussed, then it's a matter of the daughter finding a midpoint and the mom finding a midpoint and understanding, yeah, my daughter doesn't want me to die. And the daughter understanding apple pie is essential for her. So you negotiate, and it's not going to happen overnight, but it's a conversation that must be had, and that is going to make a difference. So we definitely need to bring the families as collaborators, as part of the team that provides care. There was a question of the refusal from the clinician to change the care. So the easy question would be, well, you find another clinician that is willing to work with you and get your priorities done. Sometimes it's not that easy because there's a limited number of geriatricians and there's a limited number of clinicians that can help you. But clinicians are usually, they might be very stubborn, but they usually listen eventually. So it's a matter of having the conversation over and over. And I think if you're very specific and say, so doc, this is what's important to me. Do we need all this medications for me to be able to just walk the dog twice a week in the park? Yes, it is. Okay. And then you ask the following visit, and then you ask the following visit. And Eventually, it needs to change. But it needs to be an open conversation where you write down the things that are important to you and have an open discussion saying, this is what's really important to me. I don't care if I die tomorrow because this is my priority. And I think clinicians a lot of the time don't feel comfortable with stopping medications or not following the guidelines because they're afraid that the person will die. They're afraid that the family is going to sue them because they stopped the medication that was by the guidelines. But if we move past that and we understand that the patient is okay with those things that I'm afraid of, then that's fine. If a patient tells me, you know what, if I die tomorrow, that's fine. I'm happy. I'm 92. I did what I needed to do. I just want to be free of pain. Okay, then I'll increase the dose of the pain medication, and that's fine. And at least that's my approach. I know that not all of my colleagues agree with that, but it requires, like with anything else, it requires clear communication and education, which is hard to do sometimes.
Thank you very much, Melissa. Dr. Samper, it seems that you spent her life working and negotiating, and now we move into the other facet of growing old, but also negotiating with oneself, with family, with clinicians, and even dealing with the environment around us. I do believe that the presentation that you have both excellently shared with us will no doubt motivate other questions and comments from our colleagues. So I guess the association will find a way of challenging these. There is still a lot of this topic to be discussed, and we would hope to see you again. Because of the time constraint, I'm going to hand over to Martha. But growing old is a process. You are both still young. I am 66, my mother is 97, and learning to take care of her and accepting that I have to take care of myself now has been a process, not only of negotiation, but as Melissa said, of adapting to these changes and these realities. I live in Nicaragua. We do not have many facilities or clinicians, geriatricians to address. So you usually tend to go to your primary physician who may be older than oneself, which is another level of negotiation because they're set in their ways. And as we always say, you can't, it's hard to teach old dogs new tricks. But perhaps if we ourselves are empowered and take control over care, we may find the elements and the tools to make these changes and try to find the answers required to the new tricks. So I personally want to thank you very much. I think you have provided a lot of food for thought, but more so what was mentioned on several moments, the need to take and assume the self-responsibility of my decisions and my quality of life. So thank you very much. I am going to hand over to Martha, and I would like to ask our colleagues from the audience to forward any questions or further observations they have to the association, and we will find how to deal with it. Have a good day. It has been a pleasure and a privilege to meet you, Dr. Samper, Melissa. Your surname is a little complicated, so I prefer to move to first name. For this opportunity, and I hope that we will see you again. Martha, the floor is yours.
Thank you, Gina, and I now want to ask Patricia Morge, who is the advisor for healthy aging at PAHO, to give us the concluding remarks for this presentation.
Thank you, Martha. Thank you all very much to the panelists and to the public for being here with us today. And thank you very much to the Association of Former Staff Members of PAHO, WHO, for organizing this event, and more importantly, for moving forward the topic of healthy aging among their members through the creation of the Healthy Aging Committee. We, from the PAHO's Healthy Aging team, appreciate the opportunity to be working with the association and for this webinar that we had today to share and discuss about self-efficacy, managing health, and communicating health priorities through specific goals and preferences. with a great presentation from Melissa and tips on how to do so, like how to identify the goals and communicate effectively, which was very well presented by Rafael. This is so important to guarantee optimal care for older persons, considering their priorities and making them protagonists of their own health and care. Who has been stating the importance of that to promote the person-centered care in all strategies related to healthy aging, including the decade of healthy aging. So before wrapping up, I would like to invite you to a webinar on the regional launch of the Global Report on Ageism, which will be on May the 10th at 10 a.m. Eastern Time. The Global Report is one of the main documents that is guiding the United Nations global campaign to combat ageism, and combating ageism is also one of the action areas of the decade of healthy aging. So to be involved in the movement, I invite you to participate on this webinar, and the link to register was posted earlier on the chat, as well as other opportunities and other ways to find information on healthy aging and the work that we are conducting in the association and as well as in PAHO in the Healthy Aging Program. So I hope to see you all there at our event and also in the next upcoming events from the association, which we will be announcing shortly. So thank you very much for your presence here today, for the panelists, and for the opportunity to be sharing today at this great event. Thank you. See you all soon.
Thank you very much, Patricia. And with this, we conclude today's webinar, but this is only first one in a series that we'll be announcing very shortly. Thank you.
Bye, everyone.